Hello, and welcome to the 2022 LACNETS December webinar. I'm Lisa Yen, Director of Programs and Outreach for LACNETS.
And I'm Heather Davis, the Associate Director of Advocacy and Outreach at LACNETS.
We look forward to our presentation by Dr. Thor Halfdanarson titled 2022 Year in Review, followed by a live question and answer session. A special thanks to Ipsen Advanced Accelerator Applications and ITM Pharmaceuticals for supporting our LACNETS patient education programs. Last month, during our NET Cancer Day Symposium, we shared the news that LACNETS is rebranding as Learn, Advocate, Connect, a neuroendocrine tumor society. You will see our new logo on our social media, emails, and our new website. 10 years ago, in 2012, NET patient Giovanna Joyce Mbesi launched a small local support group called Los Angeles Carcinoid Neuroendocrine Tumor Society, more commonly known as LACNETS. Her desire was to spread hope to NET patients and caregivers by empowering them with relevant educational programs and by building a community for NET patients and caregivers to connect with each other. LACNETS is now one of the largest NET patient and caregiver advocacy groups in the country. 80% of those reached by LACNETS live outside of California, and of those, 15% live outside of the United States. Our old name no longer represents our true reach, impact, and inclusivity. Our new name allows us to retain the acronym LACNETS and build on the recognition and goodwill we have built over the last decade. The new LACNETS logo establishes us as an inclusive national and international organization. The keyboard pattern is a nod to our founder, Giovanna Joyce Mbesi, a talented pianist and composer, and it is also a reference to zebras, a mascot for the neuroendocrine community. Why are zebras associated with neuroendocrine cancer? It's because in the medical world, a zebra is a symbol for rare diseases. In fact, medical students are taught, when you hear hoofbeats, think horses, not zebras, meaning they are taught to think of the more common diseases and diagnoses rather than the less common ones. And thanks to the growing awareness, neuroendocrine cancer is now less rare than previously thought. Another reason for the zebra mascot is that each zebra has its own unique pattern of stripes, and the same can be said of neuroendocrine cancer patients, that each person is unique in their presentation, diagnosis, and treatment. Our mission at LACNETS is to provide education, advocacy, and support for all people impacted by this uncommon disease that used to be known as carcinoid, an old term meaning cancer-like. You'll often hear us say neuroendocrine cancer as a patient-friendly way to say the official medical term neuroendocrine neoplasm, which is the umbrella term for both neuroendocrine tumor, or NET, and neuroendocrine carcinoma, or NEC. We also say neuroendocrine cancer because we understand it is a type of cancer and not cancer-like or benign as previously thought. While you often see Heather and I leading meetings and programs, we are led by a team under the leadership of our Executive Director, Kavya Vellakuputi, who has been with LACNETS since 2015. Our board includes Donna Gavin, who is also the sister of LACNETS founder Giovanna Joyce Mbesi, and it also includes NET patient Mary Dunleavy, who has been living and thriving with NET for 18 years. I'm now going to hand it over to Heather to share some important tips about today's webinar.
Thank you, Lisa. Be sure you're following LACNETS on social media to stay up to date on upcoming webinars and NET news. We are on Facebook, Twitter, and Instagram with the handle @LACNETS. And please be sure to add us to your safe sender email list. I'd like to remind our audience that LACNETS webinars are created for educational purposes only and do not substitute for medical advice. The views shared in the webinar are the personal opinions of the experts. Please contact your medical team with questions or concerns about your individual care or treatment. And now I'll hand it back over to Lisa.
Thank you, Heather. I'm excited to introduce our speaker, Dr. Thor Halfdanarson from Mayo Clinic Cancer Center in Rochester, Minnesota. Dr. Halfdanarson is a medical oncologist and hematologist who focuses on neuroendocrine tumors and hepatobiliary tumors. While he is interested in the management of neuroendocrine malignancies of all types and origins, he has a particular interest in high-grade neuroendocrine neoplasms, including well-differentiated neuroendocrine tumor and poorly differentiated neuroendocrine carcinoma and NETs of unknown primary site. In addition to his busy clinical practice seeing neuroendocrine cancer patients, Dr. Halfdanarson is very active in both research and education. He has countless research publications in his name, is involved with research cooperative groups, and is active in clinical trials. Dr. Halfdanarson also serves on the board of directors as the current vice president of the North American Neuroendocrine Tumor Society, LACNETS, the medical professional net organization you might often hear us refer to. He works closely with NET experts and advocacy groups globally and is frequently invited to speak at both medical and patient conferences about neuroendocrine cancer. In fact, we invited Dr. Halfdanarson to provide this overview of 2022 because he has attended most, if not all, of the major medical professional NET meetings in person this year. We understand that patients are not able to attend many of these conferences as they're usually just for medical professionals, and understandably, patients also want to know the latest advances. We are thrilled to have Dr. Halfdanarson join us to give a summary of updates from this year's major medical conferences in his presentation, 2022 Year in Review. Welcome, Dr. Halfdanarson.
Hello, my name is Thor Halfdanarson. I'm a professor of oncology at the Mayo Clinic in Rochester, Minnesota. And it is my pleasure to talk to you today about the year in review 2022, what has happened in neuroendocrine tumors and where we might be going. So these are my disclosures. Special thanks to Dr. Pamela Kunz, an associate professor of medicine and oncology at the Yale Cancer Center. So she presented at the most recent NANETS annual symposium, and she was kind to give me her slides and I've used some of her materials for this presentation. So these are my learning objectives, really to review some of the key discoveries in the neuroendocrine tumor field in 2022, and to try to identify relevant and practice-changing discoveries. And actually the third one could be, where are we going? What trials do we have for the future? Where should we be focusing our attention? So this is how the content of my talk. I'm going to start with the basic and translational science research, move into some of the clinical trials, then some of the what we call observational studies, which are not like clinical trials, but trials looking at important treatment questions. And then there are a few studies that don't really fit into any of the groups I'll discuss at the end. So where do these results come from? So these are published studies from scientific journals. These are studies presented at multiple different scientific conferences this year, including the American Society of Medical Oncology, ASCO, the European Society of Medical Oncology, ESMO, and then NANETS, which is the North American Neuroendocrine Tumor Society, and the European Neuroendocrine Tumor Society, ENETS, and then there are some others as well. We'll start with the basic and translational science research, and some of this will be a little technical, but I'll try to explain it as best I can. So the first one I wanted to talk to you are actually two studies that looked at multifocal small bowel neuroendocrine tumors. So these are the carcinoma tumors with the small bowel. We've known for years that 50% of patients with intestinal, well-differentiated small bowel neuroendocrine tumors have more than one tumor. We call them multifocal tumors. And we've never really known if these were like one mother tumor and others were metastases, if they were all the same. But now there are two studies, actually three if we count the study from 2021, that suggest that these multifocal neuroendocrine tumors may actually arise independently of each other. So they're different genetically. And even if there is a difference in the expression of somatin receptors and the serotonin and CTX2 and other markers, the tumor grade is typically the same, and it doesn't look like this difference affects prognosis. So the other thing that was discovered in these studies this year is that patients with multiple different small bowel primary tumors can have multiple metastases that can come from different tumors in the small bowel. So this is, I think, a relatively new discovery. It's very important that we understand that these different multifocal small bowel tumors are somewhat independent, and I would not say unrelated, but they definitely can be different from each other. How this will eventually affect how we treat patients remains to be seen. Right now, everyone should be treated the same. but it's just an area for further discovery. So let's talk next about what's called germline genetics. So germline mutations are mutations you're actually born with, or mutations that are inherent to your own genetic material. That's sort of different than what we call somatic mutations, which are mutations that are limited to the actual tumor. So there have been 2 studies this year looking at germline genetics. So mutations that we're born with that we can actually detect in the blood, not in the tumor. So one was from Dana-Farber in Boston. So of 88 small intestinal neuron tumors, 9 to 11% had a pathogenic germline variant, and we list a few of the mutations there. But they went on to say that these mutations are there, we can detect them, but we don't really know how much these variants increase the risk of developing small bowel neuron tumors. So this is definitely something that needs to be explored. There was another slightly smaller study presented at this year's LACNETS by Bassam Sunbal, who is one of our neuroendocrine oncology colleagues at Mayo in Arizona. So he looked at 55 neuron tumor patients, mostly pancreatic neuron tumors. And he found what was called pathogenic germline variant in almost 15%. And similar genes as in the study from Boston, a couple of additional genes not reported by the Boston team. And the prevalence of these mutations was almost 16% in pancreatic neuron tumors, less in other neuron tumors. And then we detected what's called variants of unknown significance. So these are mutations we don't really know what they mean. And they were seen in up to 40%. We're not sure what to do with that. And then lastly, 5 patients had mutations or variants of unknown significance in genes that code for what's called mismatch repair proteins. And of the 4 patients with such a variant, we were actually able to test for what's called mismatch repair deficiency, and 2 of them were deficient. And why does this matter? Well, this could actually matter because these might be the patients who could be sensitive to immunotherapy. So this is definitely an area that needs to be explored further with larger studies and even combination of genetic studies from different places. So moving on to liquid biopsies are a really hot topic in oncology these days. So typically when we want to know about the mutations in the tumor, we have to get a piece of the tumor with a needle, we have to send that to the lab, and they do very sophisticated genomic studies on that, and they tell us what genes are mutated or what genes are what we call deleted, or sometimes there is what's called gene fusion, where one gene has sort of broken apart and fused with another gene, and those can be targetable with some of those newer drugs that we have. But we also have these tests where we can do a blood test and detect what's called the circulating tumor DNA in the blood. And that may give us an idea about what the tumor is up to. And this could be important, especially if there is a tumor in a location that's hard to biopsy. Let's say if there are bone metastases, they can be hard to biopsy and hard to process, such that we can actually work on the tumor tissue from the bone. Sometimes the way we have to handle the bone biopsies makes it very hard to do genetic testing. So in this study presented at ESMO, there were 50 patients, including 46 with metastases. And the potentially targetable mutations, where we might actually have a drug, were seen in 52% of patients with GI neuroendocrine carcinomas. And I want to emphasize this is carcinomas. These are the poorly differentiated aggressive neuroendocrine carcinomas. And of those, 18% had mutations that were only detected in blood. And as we can see on the little picture there in the right upper corner, is how they compared tumor biopsies and liquid biopsies. And as we can see, 71% of them had the same mutations in both the blood test and the tumor biopsy. But there were 29% who had mutations detected. Actually, 18%, I believe, had the mutations detected only in blood. So really, the bottom line here is that the liquid biopsies seem to work. They may identify targetable mutations in up to 50% of patients, and they may actually find mutations that are not found with other tests. So it's definitely something to keep in mind. And now one has to ask the question, should we do both tumor and liquid biopsies? And that's something to be discussed later and actually to be explored later. So quickly here, a little bit more on the genomic characteristics of neuroendocrine carcinoma. So we saw a number of studies on the genomics of neuroendocrine carcinomas in 22, and these tumors are genetically different from one another. So, for example, the pancreatic neuroendocrine carcinomas are different than the colorectal neuroendocrine carcinomas, the colorectal neuroendocrine carcinomas have some mutations we see in colorectal adenocarcinoma or the common colon cancer. And there might be even more than one type of pancreatic neuroendocrine carcinoma. So what this means to me is that if these tumors are so different genetically, shouldn't we be treating them differently? Do we really expect that a one-size-fits-all approach will really work here? So right now we've been treating these patients with the same treatment, with platinum, etoposide, but one wonders with the genetic differences, should we be treating them differently? So let's move on to the clinical trials. So let's first start with the well-differentiated neuroendocrine tumors. So we had this study presented at this year's ASCO and then published in the Journal of Clinical Oncology by Dr. Kunz at Yale. So this is a study we've all been waiting for. So we've known the results for a few years, sort of the preliminary results. In this study, looking at patients with pancreatic neuroendocrine tumors, not neuroendocrine carcinomas, 144 patients were randomized to either receive capecitabine and temozolomide or CAPTEM or temozolomide alone. The question here is, does the capecitabine add to temozolomide? And the primary endpoint of the study, sort of the part we were mostly interested in learning about, was the progression-free survival, but then also the objective response rate, so how often do the tumors shrink, the overall survival, and then obviously safety and toxicity. That's super important to know. So into the results. The combination therapy with CAPTEM was more effective. If you look at these two graphs, and if you look at what's called the median overall survival, it was almost, not quite twice as long in the combination CAPTEM arm, but 22.7 months. That's the time on average it took for the tumors to grow. And versus 14.4 months in temozolomide alone. If we look at the objective response rate, 40% of patients in the CAPTEM group saw a substantial tumor shrinkage and 34% in the temozolomide alone. But the message here is the progression-free survival. If you look at what's called the adverse events in the little table at the bottom, the G3, G4, these are grade 3, grade 4 side effects. So grade 3 and grade 4 are the side effects that are getting really bothersome. So 44% in CAPTEM versus 22% with temozolomide. So the combination doubled the side effect risk, but I will say that most of these side effects are fairly manageable. A lot of it is low blood counts, things we can work around by adjusting the doses and things of that nature. So I will say that the CAPTEM is now, as per this study and others, it's effective and it's well tolerated. Although these numbers indicate it's not that well tolerated, but in practice, it's actually a very well tolerated treatment. So this is the overall survival. So that's looking at the life expectancy of patients. That wasn't really that different. So with the CAPTEM, 58.7 months versus 53.8 months, and keep in mind that this study was done years ago. We have now other treatments that may benefit patients who were on this study. So I just always want to warn you, take these survival numbers with a grain of salt. So it wasn't really much of a difference in the overall survival there. But so there's this test called MGMT, and we can test the tumor for this, what's called MGMT deficiency, and this may predict how likely the tumor is to respond to therapy with temozolomide. This study that Dr. Kunz published and her team at ECOG showed that if you have this MGMT deficiency, you're more likely to have a better response. But that said, some people who don't have that MGMT deficiency will still respond. So we don't really know what to use these data for, other than to say if we have someone who we really need to see a good tumor shrinkage, and more likely to see that if you have MGMT deficiency. So the SECTOR study, so this was a study presented at ESMO a few months ago. So this study looked at patients with advanced grade 1, grade 2 pancreatic neuroendocrine tumors who had not received any chemotherapy or everolimus or any what's called kinase inhibitors, could have been on prior somatostatin analog therapy, so injections with octreotide or lanreotide. In this study, the patients were randomized to either everolimus, Refinitor, or an old chemotherapy called streptozotocin, which we used a lot back in my training, but we haven't really used that much in the US. So the primary endpoint of this study was really the progression-free survival, the time it took from starting the study until there was notable tumor growth. And at that time, the patients who started with everolimus could switch over to streptozotocin. Those who started with streptozotocin could switch over to everolimus. So this study showed there wasn't really much of a difference in terms of median progression-free survival. We can see it's almost identical there for Afinitor or everolimus, 21.5 months, for streptozotocin, 23.6. So a similar efficacy. I will say in the past when I was giving streptozotocin, it was quite a bit more toxic than the everolimus is, but in this study, there didn't really seem to be that much of a difference. So these graphs, these are called waterfall plots. Every column on this graph represents one patient. So all of those that are going up above the zero line in the middle there, those are patients where the tumors actually grew on the study. Where we can see the columns going down, those are the responses. And the dotted line below the zero line is what's called the 30% response rate. And that's really what we use as a definition of a partial response. So where there has been more than 30% shrinkage in the tumor size. And as you can see there, the patients who received the streptozotocin were more likely to have tumor shrinkage than those who received the everolimus. But keep in mind that most of the time we're not so much going for tumor shrinkage, we're more going for survival and toxicity. So I would much rather have less tumor shrinkage but well-tolerated therapy that lasts a long time than have something that really shrinks the tumor but doesn't keep it down for very long. So moving on, if we look at the side effects there were some differences. So, for example, the streptozotocin was more likely to cause nausea. The everolimus was more likely to cause infections and inflammation of the lungs and high blood sugar. So, but at the end of the day, there was actually surprisingly little difference, I thought, in the two drugs in terms of side effects. So moving on to this study, the Octal random study, this is a study we have been waiting for as well. So this was a study presented at ESMO. So in this study, patients with progressive pancreatic neuroendocrine tumors who had mostly been on somatostatin analog therapy and were randomized either to lutetium octreotide, which is lutetium 177 dotatate, which is the conventional PRRT that we use, or sunitinib, which is what's called a kinase inhibitor and has been approved for pancreatic neuroendocrine tumors for years. So essentially comparing these two approaches, PRRT versus sunitinib, and let's see who did better. Well, no question here who did better. So the PRRT was much more effective. That's the blue line at the top there. The red line is the sunitinib. And if we look at what's called the 12-month progression-free survival, that's the percentage of patients with no tumor growth and still alive at 1 year from starting therapy, 80% for PRRT, 42% for sunitinib. So definitely a big difference. And this comes as no surprise. But that does not mean sunitinib is a bad drug and shouldn't be used. It just means that the PRRT in this setting, it gives you more mileage. So this study is went below the radar for many. So it's a well-done study done in China, a randomized phase 2 study looking at 140 patients with pancreatic and non-pancreatic neuroendocrine tumors, grade 1, grade 2, and well-differentiated grade 3. And they also allowed the LACNETS. And it was looking at a combination of temozolomide, the TMZ, and the chemotherapy called S1, which is sort of similar to 5-FU or capecitabine. And then the other arm looked at the addition of thalidomide, which is obviously a drug with a really bad reputation, causing birth defects. This goes back to the 60s and 70s, but it's a drug that has been used for certain blood cancers and actually does possibly have activity in neuroendocrine tumors. It made sense to test it. And the primary endpoint here was overall response rate, but there were some other endpoints too. So how did these two regimens do? Well, if you look at all of the patients, so pancreatic and non-pancreatic neuroendocrine tumors, there was not really any difference. So adding thalidomide to the chemotherapy alone didn't really result in any better outcomes. So I think that sort of settled that question. I don't think thalidomide has a future in neuroendocrine tumors. And they also looked at the MGMT. Remember that marker that we can test the tumor for that may predict if the tumor shrinks. So what we've always wanted to know, if there is MGMT deficiency, do the patients go further? We've known from the ECOG study Dr. Kunz presented that there's a higher response rate, but what about the progression-free survival? And this study actually showed that if you have MGMT deficiency, the progression-free survival is 19.1 months versus 5.4 if you did not have it. So I think MGMT is something we're going to see in future studies. I'm not saying this is ready for clinical use, but I think it's certainly something that needs some more exploration. So the next slide is a little busy. So really what I wanted to show with this slide is that we have these 4 graphs. So on the left-hand side, we have what's called the progression-free survival for pancreatic and non-pancreatic. And so at the time of this publication, not all of these milestones had been reached, and that's what this NR stands for in the little tables, that it's not reported or not reached. So if you look at the progression-free survival in non-pancreatic neuron tumors, the combination of S1 and temozolomide resulted in 7.4-month progression-free survival. But for the pancreatic neuron tumors, definitely better, and that was not reached. So this just goes to show that the temozolomide-based regimen is actually more active in pancreatic neuron tumors. And then we have the overall survival curves there. And for pancreatic neuron tumors, the overall survival was not reached. That's the graph in the bottom right corner. But for the non-pancreatic neuron tumors, the overall survival was 27.5 months, which is a little unusual because I would have expected something more than that. But it sort of all depends on what were these patients like when they went in the study, what treatments did they receive after they came off this trial. So again, take those overall survival numbers with a grain of salt. So to summarize these 4 trials, so ECOG 2211, the combination of CAPE-TEM has a longer progression-free survival and higher objective response rate than temozolomide alone, and MGMT status is associated with a higher response rate. The SECTOR study showed that everolimus and streptozocin have similar efficacy in terms of progression-free survival and side effects, but the objective response rate was higher with streptozocin. And then we have the ocular random study that showed very convincingly that PRRT had a longer PFS than sunitinib. No surprises there, we all expected that. And then lastly, the STEM study, that's the S1 temozolomide thalidomide study, showed there was no benefit of adding thalidomide. And again, MGMT status is associated with response. So let's move on to trials in poorly differentiated neurocarcinomas. Carcinomas. So what happened there in 2022? So we saw this study presented at the ASCO this year. So this was a study of 58 patients, small study. They actually planned to have 102 patients, but they only looked at 58. So in this study, patients were randomized to either docetaxel or what's called nanoliposomal irinotecan with 5-FU and leucovorin. So it's a colon cancer-like chemotherapy or pancreatic cancer-like chemotherapy. In this study, you had to have what's called an extrapulmonary neuroendocrine carcinoma, so a neuroendocrine carcinoma not starting in the lungs. Everyone had to have prior first-line therapy with platinum-based chemotherapy, so platinum and etoposide for most of them. And they had to have progressive cancer, and they had to be in reasonably good shape. And the primary endpoint for this study was 6-month progression-free survival. So at the 6-month point from starting the study, how many of the patients were still alive and did not have progressive disease? And then there were some other secondary endpoints. And it's very important to point out that this is second-line chemotherapy. This is not first-line chemotherapy. So the overall survival was slightly longer in the what's called the NALIRI nanoliposomal irinotecan group, 9 months versus 5 months. But keep in mind there were a small number of patients there. If we look at the primary endpoint, the progression-free survival at 6 months, the NALIRI was better, 31% versus docetaxel, which was only 13, but you see that relatively few patients met that endpoint. And if we go down here and we look at the objective response rate, the tumor shrinkage relatively low, 10.3 for both groups. And then if we move on to the progression-free survival, that's what I found very disappointing. So if we look at the average time until progression, 3 months with NALIRI, 2 months with docetaxel. So yes, the NALIRI seems to be slightly better, but both regimens, I would say, are relatively ineffective. So better treatments are definitely needed. So moving on to the next study, the PROTEAGE 41 Bevanec. So here the question was, again, using colon cancer-like therapy called FOLFIRI, which is irinotecan, 5-FU, and leucovorin. And here they added bevacizumab, which is a drug that is thought to interact with the blood flow to the tumors and is commonly used and approved for multiple cancers, including colon cancer. So here, patients with refractory gastroenteropancreatic or unknown primary neuroendocrine carcinoma who all had prior platinum chemotherapy were randomized either to FOLFIRI with bevacizumab, also known as Avastin, and FOLFIRI. And let's see how that all went. So as I said, second-line therapy, And as we can see here, there wasn't really much of a difference. The bevacizumab arm, the FOLFIRI-bevacizumab arm, had a slightly lower median overall survival and overall survival at 6 months, as you can see there. That's the black line on the graph. The red line is the FOLFIRI alone. So this was not statistically significant, but there was the bottom line is that there's no added benefit of bevacizumab. So we know that now. And what more importantly for this study, it actually shows that in these patients with neuroendocrine carcinoma progressing on first-line therapy with platinum and etoposide, FOLFIRI actually works. And now the question is that from the previous study with a different type of irinotecan called nanoliposomal irinotecan, is that any better than the good old irinotecan? We're probably never going to see a study comparing those two. But both of these studies show that there is benefit of using irinotecan chemotherapy in patients who have previously received a chemotherapy with platinum and etoposide. Not shown in this presentation is that at this stage, for many of my patients, this is where I consider immunotherapy. So with what's called a dual immunotherapy with a drug called nivolumab and a drug called ipilimumab. So in second or third line therapy, that's where I would like to do that. We know from our experience, years and years of experience, that after the first line chemotherapy in neuroendocrine carcinoma, old-fashioned chemotherapy just doesn't work that well. So this would be where I would really encourage everyone to look for a clinical trial and consider immunotherapy. So this study was presented at ASCO as well. So this was a study from this group called ECOG and another group called ACRIN. So in this study, patients with grade 3 neuroendocrine neoplasms, both well-differentiated neuroendocrine tumors and poorly differentiated neuroendocrine carcinoma, they were randomized to either CAPTEM, that's the drug, the combination we were talking about a little bit earlier, or platinum and etoposide. That's the first-line therapy we typically use for neuroendocrine carcinoma. So these were patients who were previously untreated. This study, in retrospect, when we look back, had some design issues. We probably should not have combined neuroendocrine carcinoma and well-differentiated grade 3 neuroendocrine tumors in the same study. So this study accrued very slowly in the US. Practitioners had a lot of issues with it. I was a part of this team, I will say, and we did put patients on this study, but it closed early due to futility. Clinicians were just not enrolling on it. And what we could glean from it is that there was no difference in these two regimens. But really the message here is that if we do a study like this in the future, we need to have the neuroendocrine carcinomas separate from the neuroendocrine tumors. So the well-differentiated separate from poorly differentiated. So this is a study that got published this year. So this is not from a meeting. This is from one of the major oncology journals called JAMA Oncology. So this is a study from Japan. So this is a really well done study. And it's first-line therapy, no previous therapy, neuroendocrine carcinoma, 170 patients, impressive numbers. And here the randomization was very simple. Cisplatin plus etoposide, which is the standard and has been for many, many years. And the comparator was cisplatin and irinotecan. So that irinotecan drug is now being used up front. And really the results here were that there was no difference. The progression-free survival and overall survival were very comparable. So here we have evidence that we can actually use both of these regimens, at least in this population in Japan. I will say that due to some genetic differences, sort of on how we metabolize drugs, studies that work in Asia, let's say in Japan, China, Korea, especially with irinotecan, haven't always panned out in the US. And I think it has something to do with the way the body handles the drug. But this is an important study suggesting that we actually have these two options, cisplatin etoposide versus cisplatin with irinotecan. And in terms of side effects, they were somewhat similar, but there were subtle differences there. So to summarize all of this, is that with the NATO2 study, so the Naliri 5FU had a modestly longer progression-free survival and overall survival, but the outcomes in both groups were pretty poor. The BEVANEX study showed there was no added benefit from bevacizumab when added to FOLFIRI, but FOLFIRI works. So that's important information in its own. And then we have the ECOG ACRIN 2142. In retrospect, not an ideal study design and no difference, but the trial closed early. They didn't get all the patients they wanted. So in the future, we should have different trials for these very different types of tumors. And lastly, the TOPIC-NEXT study from Japan. etoposide platinum versus irinotecan platinum, both seem to be equally effective. I wouldn't call them very effective, but they're equally effective. Okay, so let's move on to other clinical trials and trials of importance. So you all may have heard of alpha particle therapy. So this is the next generation of PRRT, if you will. So in this therapy uses a different radionuclide, could be actinium or lead instead of lutetium-177, and is theoretically more effective. It's a higher energy radiation with a shorter path length, so possibly also better tolerated. That all remains to be seen. So what I wanted to show you here is that on the left-hand side, there was a trial done in India looking at actinium-225 PRRT with capecitabine. 91 patients went on this study. 63% of them received prior lutetium-177 PRRT or Lutathera. 22% of them had prior chemotherapy. 33% were pancreatic neuroendocrine tumors. And actually 31% of them were in pretty rough shape with a performance status of 2 to 3. And that's where you really need substantial assistance with the activities of daily living. That is very, very unique to allow patients this sick on a clinical trial, but it probably goes to show how the need for actually I think we need more trials that allow patients in less good performance to enroll, because that's probably the population that needs this the most. But we've got to be careful because the patients with less good performance are also at higher risk of side effects. So here the 24-month overall survival was 71%. So at 2 years, 71% of these patients who were pretty heavily pretreated were still alive. And those who had previously had prior PRRT, their average survival was 26 months. And the progression-free survival was around the same, 68% at 2 years. Overall response rates, 52%, actually higher than we see with Lutathera. And then on the right-hand side, much smaller trial from Excel Diagnostics in Texas, another really well-done study. So looking at what's called dose escalation, so going up on the dose of a different alpha particle therapy called 212 lead or dotentate. And in this small study, 80% objective responses. And those little pictures that below are from their publications, just showing sort of before and after. And you can see the first one, all of the liver lesions, all of the bone lesions there that disappeared after 212 lead therapy. So this group in Texas has a trial open, and it's definitely worth considering that. I think they are still accruing, so something to keep in mind. More alpha particle studies are coming. I'm just going to tell you that. So I wanted to bring to your attention a few trials that are ongoing. These are very important trials. Alliance for Clinical Trials in Oncology is an organization that runs trials all over the US. It's one of the several what's called cooperative groups. One is Alliance, one is the Eastern Cooperative Oncology Group, or ECOG. There's a Southwest Oncology Group called SWOG, and there are some others. And these are always carefully thought out, high-quality clinical trials. So in this study, it's looking at what is the ideal sequence of therapy after progression. Somatostatin analogs for patients with well-differentiated pancreatic neuroendocrine tumors. We have a lot of options, but we don't know what is the best option. It's a randomized phase 2 study. Patients with pancreatic NETs progressing on first-line somatostatin analog therapy will be randomized either to CAPTEM, which we know is effective, or to PRRT, which we also know is effective. But we want to know, is there a difference in these two regimens? Is one better than other? Is one more toxic than another? So this is a really important study to do. We definitely need to get this done. Very similarly, another study is looking at PRRT in lung neuroendocrine tumors. I often hear from patients and advocacy groups that the lung NETs are not being served well in clinical trials, and that is true. So I think we need to put emphasis on lung NETs. They are common, they are understudied, and this is a trial that tries to address that. So in this study, patients who have either received no therapy or previous therapy are randomized to either 4 cycles of PRRT or everolimus, which is FDA approved. And here the primary endpoint is progression-free survival. Another incredibly important study to get done. We really have so little data in lung NETs, so I think it's important to consider this study for appropriate patients. NETTER-2 was a study that looked at first-line PRRT and high-risk grade 2 neuroendocrine tumors and well-differentiated grade 3 neuroendocrine tumors. This study was planning on enrolling about 200 patients, if I recall right. They got to that mark in October. So all of the patients on this, here the untreated patients either got upfront PRRT, and it's actually not the 1-to-1 randomization, it was 1-to-2 randomization. So if you went on this study, you had a 67% chance of ending up on PRRT, a 33% chance of getting double dose octreotide, and then there was a crossover for those who got the octreotide. If the tumors grew, they could cross over to the PRRT arm. This study is done. We haven't seen the data yet, so keep an eye out for this. This could potentially be a practice-changing study when we get the results. So thankfully, we have another study somewhat similar to this one called Compose. And this study is looking at a very similar patient population, slightly higher tumor grade with either first or second line therapy. They have to obviously be positive on someone's PET scan or gallium or copper dotatate PET scan. And here the randomization is either 6 cycles of lutetium-177 etotriotide, also known as Dotatalk, not dotatate. So it's slightly different, 6 cycles versus 4. And the comparator arm is either CATEM or everolimus or FOLFOX, and that's the physicians and the patient physician. So in this study, we sat down with the patient and we talked to them about the options, and then we pick one of the comparator arm. So this study recently launched in the US, and a very important study to consider as well for appropriate patients. This study is also ongoing. This is looking at treating again with PRRT, what's called PRRT retreatment. And in this study, patients with mid-gut neuroendocrine tumors who have progressed after prior PRRT with Lutathera and have gone for 12 months or more without progression, are randomized either to PRRT again for 2 cycles or everolimus. Very, very important question. Another study that has to be completed. My only concern with this study, and it may not be a real concern, is that when the alpha particle studies open, some patients might be more inclined to go on an alpha particle study than go on this study. But I think this is still a very good option for a trial. So please keep this one in mind if you can. These are the active trials in the US for neuroendocrine tumors. So we have studies for bronchial nets, we talked about those. We have studies for paragangliomas and pheochromocytomas, which are kind of neuroendocrine tumors. We have studies for poorly differentiated neuroendocrine carcinomas, looking at immunotherapy plus chemotherapy versus chemotherapy alone. And we have studies looking at embolization therapy to liver metastases. We have an alpha particle study coming, and then we have a whole list of phase 1 studies looking at different treatments for patients with both well-differentiated and poorly differentiated neuroendocrine tumors. But there are 2 trials I just wanted to bring to your attention. So they are at the bottom of the list there. So one of them is called Sorrento. So this is a study looking at self-administered subcutaneous octreotide called CAM 2029. Versus either lanreotide or octreotide. So as you know, neuroendocrine tumor patients who are in need of somatostatin analog therapy, they have to come to the clinic to get injected. So this drug is actually self-injected, subcutaneous every 2 weeks, comparing it to the standard treatment. So if this study is open anywhere near you, keep it in mind. Another study is looking at an oral somatostatin 2 agonist called paltusotine. So this is a very small study looking at patients with carcinoid syndrome. So here we're actually looking at a drug that is orally active against the somatostatin receptor. And although this study is only looking at symptom control, I would hope that this will eventually move into larger studies looking at tumor control. So this looks at getting rid of the injections for an oral drug. So exciting development there. So a few observational studies, I'll go fairly quickly through these, and looking at the treatment outcomes. So this is a large retrospective study from Italy. 508 patients with the liver metastases, all had previous somatostatin analog therapy, received PRRT and targeted therapy or chemotherapy. And what they wanted to look at here was the outcomes of patients who started with chemotherapy or targeted therapy or started with PRRT after progression on somatostatin analog therapy. And this is not a randomized clinical trial. And if you look at the progression-free survival, the orange curve, that's the PRRT. So that the PFS, or progression-free survival, in that group was 2.2 years versus 0.6 years in the chemotherapy or a targeted therapy arm. But if you look at the bottom graph there, that's the overall survival. There was no significant difference. But the message here is that in this group of patients with metastatic disease progressing on somatostatin analog therapy, we're looking at overall survival of 11 to 12 years. And this is not accounting for some of the new advances, including alpha particle therapy. It just goes to show that we've come a long way. We're now actually seeing patients routinely live beyond 10 years with metastatic disease, which is very, very remarkable. So this is a study from Dr. Das at Vanderbilt. He looked at a scoring system to predict efficacy of PRRT, looking at the symptoms and tumor bulk and peritoneal carcinomatosis and prior therapy, and what he was able to show that you could create this scoring system that could actually sort of to some extent predict the mileage you get out of the PRRT. So this scoring system, I think, should be built into future trials. We will need more data on this, but this is really exciting. This is no additional cost. This is just getting clinical data, putting it into a scoring system, and trying to predict how PRRT will work. This study, called the ASPEN, looked at 540 patients with small, non-functional pancreatic neuroendocrine tumors. And the question was, do we have to operate, or can we just watch? So 500 patients ended up being included. 406 of them had active surveillance, so no surgery. 94 had surgery. And the reason for the surgery was many different reasons. Some people just wanted surgery, and you know how that is. Others were not comfortable with observation, and but most were actually observed. And in those 406 patients who had observation, after average follow-up time of 25 months, only 2% of them required surgery. So what this shows is, at least in the short term, if you have a small neuron tumor of pancreas that's not producing any symptoms and is a low-grade tumor, you can actually watch them. You don't have to operate. So that's safe. And this is a study just got published a few weeks ago, a relatively small retrospective study of grade 3 well-differentiated neuron tumors. They looked at different treatments there. And really what they showed there is that CAPTEM is actually effective for this. Well, they reported the progression-free survival of 20.6 months. Somatostatin analogs have some activity. And platinum etoposide, which is not an uncommonly recommended regimen, is not very effective. Last week, I saw a patient with a well-differentiated grade 3 neuroendocrine tumor, and she had been recommended to get cisplatin etoposide. So with those progression-free survival of 2.4 months and a lot of toxicity, I was not in agreement. I thought we had other better treatments, less toxic, more tolerable, so we're actually going to go with something different. Other notable studies. This is a study that looked at the prevalence of psychiatric illness in NET patients. So we've always heard that patients with neuroendocrine tumors might be more likely to have psychiatric disorders. And this study did not show there was much of a difference in psychiatric illness when they compared patients with neuroendocrine tumor with patients with colon cancer. So they chose another cancer that to compare to. And they didn't really find much difference. What they did find, there was a higher chance of severe psychiatric illness in patients with neuroendocrine tumors that produce serotonin. The difference wasn't really big, but it just suggests that if you have a carcinoid tumor that produces a lot of serotonin, it actually might have some effect on psychiatric illness. So this very interesting study just came out. I think this really needs a further study. So surgery for grade 3 neuroendocrine tumors, is it helpful? Should we do it? There was a lot of activity in this space in 2022. So there was a large, what's called a population-based study that suggested surgery was really improving survival in stage 1 and stage 2 gastroenteropancreatic neurocarcinomas, and possibly in stage 3. And there was a small study from the University of Iowa that looked at 44 patients with grade 3 neuroendocrine neoplasms, mostly well-differentiated G3 NETs. And although the survival was lower than compared to grade 1 and grade 2, it was still pretty respectable. So probably some benefit there. And another study of 55 patients suggested there was likely survival benefit in carefully selected patients. And then there was a meta-analysis where you take all of these data and put them together and analyze them together, also suggesting a benefit of surgery in carefully selected grade 3 neuroendocrine neoplasms, probably mostly well-differentiated grade 3 neuroendocrine tumors. But we've often heard we shouldn't operate on grade 3 tumors, especially not grade 3 carcinomas. But I ask you to pause there, because there might actually be some patients where surgery is really helpful. So just to summarize this is my very last slide. So 2022 was a year of multiple clinically relevant studies. So we have a much better understanding of the genetics of both well-differentiated and poorly differentiated neuroendocrine neoplasms, including germline mutations. We have several studies in well-differentiated neuroendocrine tumors that mostly confirmed what we already knew. We have a few studies in poorly differentiated neuroendocrine carcinomas that still show there's a long and difficult road ahead. We have so much work to do there. But for select patients, surgery may be appropriate. We have large observational studies confirming the long-term safety and efficacy of PRRT, and we now know that small pancreatic neuron tumors that are non-functional, less than 2 centimeters, can be observed. So that brings me to the end of my talk, so thank you very much for calling in.
Dr. Thor, thank you so much for the very thorough review of 2022. That was very informative, and I actually look forward to watching that over again because it's packed full of information. So we have a lot of questions here for you, and there's a lot of interest about many of the trials that you mentioned. A couple of them that you mentioned were the oral somatostatin analog trials. One person asked, do you think oral somatostatin analogs could be the norm soon?
I think they could be. And there is that drug that I mentioned called paltusotine, and I think I'm saying it right. So I don't know who names these drugs nowadays. So they're always hard to say. And so that's a drug that's has actually entered a clinical trial. There are some others I've heard of. So I don't think we're there yet. We need the trials. The paltusotine study will be looking at the control of carcinoid symptoms, and if that seems to work, then I think it's reasonable to look at controlling the carcinoid tumor or the neuroendocrine tumors themselves. So not there yet. Probably it will know in the next 2 to 3 years, I would hope.
Yeah, thank you. That's really exciting. So 2 to 3 years. And just to clarify, with those oral somatostatin analogs, do you think that would be more the norm for the monthly injections or for rescue shots?
Great question. I think that depends on what drugs we're going to get. Ideally, I'd like to see options for both. So the pills will probably be daily or once or twice or 3 times even daily, depending on the different drugs. So that hopefully might control the rescue shots, or might be used for rescue shots. You just take an extra pill, but those studies still haven't been done.
Great, thanks for that. And I know you didn't mention histotrypsy today, but there has been some buzz about the liver-directed therapy. What's the current status of histotrypsy in neuroendocrine tumors, and does Mayo have clinical trials in this? When do you see it being available to patients?
Yeah, so I saw this question coming, so I did a quick literature search on histotrypsy and neuroendocrine tumors, at least in the published literature, and they got 0 hits. So I've known of histotrypsy for a while. So it's at least as far as I understand, an ultrasound method of sort of delivering ultrasound waves to tumors to destroy them that way. So in a sense, it's a little bit like radio frequency or microwave ablation and even stereotactic radiation therapy. So I think this just needs to be studied. We don't have a trial at Mayo, to my knowledge. Something I'd be interested in seeing data on, but I haven't really seen any neuroendocrine tumor data yet.
Yeah, thanks. We look forward to hearing more about that as well. I know that you talked quite a bit about immunotherapy. What are your thoughts about immunotherapy, specifically in well-differentiated grade 3 neuroendocrine neoplasms?
So immunotherapy in well-differentiated neuroendocrine tumors in general has been very disappointing. So not much activity there, but that's mostly in grade 1 and grade 2. So I think there may be a role in well-differentiated grade 3, and I think we may have to eventually look at the genomic composition of the tumor. There are some thoughts that certain mutations, maybe in TP53 and RB1 and some others, might predict for activity. So I have in select patients used immunotherapy for well-differentiated grade 3. I can't say I have enough to say how well this works, but definitely something that should be done.
Yeah, okay, thanks. I know there's interest in that area. And speaking of grade 3, if a patient has the Ki-67 between 20 to 50 and well-differentiated, how different will tumors behave if they are in the Ki-67 range of 20 to 30 versus 30 to 55?
So it's a great question, and I will be honest, I don't know. So I will say that the higher the grade is, typically the more aggressive the tumors are. But also keep in mind that when we do the KSH7 grading, we just take a tiny, tiny little piece of often a very large tumor or multiple tumors. And I will say that I had the patient not too long ago who had a liver biopsy that showed the KS7 of more than 70%. We repeated the liver biopsy because we needed more tissue for molecular testing, and the second liver biopsy came back with KS67 less than 20%. So you can have the same tumor with multiple different KS67 numbers, if you will. So, but the rule of thumb is the higher the KS7 is, the more aggressive it is. We're actually going to be looking at this. Sort of what's the difference between the different KS7s within the well-differentiated grade 3 spectrum.
Yeah, more work needs to be done, and thanks for
Always
looking into this. And there's a couple of populations that may not get as much attention. One is NETs of the stomach. If there's any information on the latest advances for NETs of the stomach, that'd be appreciated.
So not a whole lot. So for the vast majority of the stomach NETs are grade 1, type 1. So type 1 neuroendocrine tumors of the stomach are neuroendocrine tumors that arise typically in a background of chronic inflammation. And if they are small, they can be removed endoscopically, and often are. Sometimes they don't even have to be removed at all. So what we've seen in 2022 and in recent years is a lot of studies and different techniques for endoscopic removal. And I think I can summarize it like this. So endoscopic removal can be done. There are several different ways of doing it, and some methods may be better than others, but it doesn't seem like there is one really superior method. As for the more advanced stomach neuroendocrine tumors, let's say with metastases and such, then we treat them like any other metastatic neuroendocrine tumor.
Okay, thank you. And this is also another population. What about treatment advances specific to cutaneous metastasis of NET?
So no specific treatment for cutaneous metastases other than if they are in locations where they are causing pain, or sometimes it can be a small metastasis in a bad location that just causes a lot of friction of the skin. Let's say if you have one under your arm, then we can excise them, ask our surgery colleagues to see if they can remove them surgically, which often is a good option, takes care of it quickly, and we even have some tissue to test if needed. I often ask radiation oncology to radiate the sort of irritating lesion. Sometimes we do it for cosmetic results if they are in exposed skin areas. Sometimes we do it if these lesions are painful or causing skin irritation.
Thanks, that's helpful. And let's switch to some of the biomarkers and blood tests. How credible and useful do you consider blood tests such as the NET test and neurokinin A marker to be? And are there any concerns that you know of?
Ongoing hot topic. So I will say that the neuroendocrine markers can be helpful, but we always go by imaging. We never make treatment decision based on marker levels. And I see a role for something like that test. So I don't use it a whole lot in the metastatic setting, but there are some data coming out that suggest that the NET test or a version of the NET test can maybe predict how active PRRT is going to be. There's a test called PPQ, which is sort of similar to the NET test. And I use that test now a little bit after surgery, complete removal of localized neuroendocrine tumors, because there were 3 studies in 2020. I did not include them in this talk because they were 2020, and but that looked at elevated NET test after surgery, and those studies showed that if the NET test was higher than 20, there was like 60 to 70% recurrence rate within 2 years. Well, we've now tested a number of patients, and we've seen that most patients probably come back with a level somewhere between 20 and 40, and so far none of them has had recurrence yet. So now I'm starting to question the utility of the NET test for this particular indication, or at least question the cutoff of 20. I think we just need to look at the NET test more carefully, and I think we need to build it into prospective clinical trials. I think it's probably the best circulating marker out there in terms of accuracy. but it just needs more study. It needs independent validation by different groups just to see if the results hold up. As for neurokinin A, as that was asked there, I don't use it. There's one study that suggests that the levels correlate with outcomes or survival. Well, I bet if you just looked at the amount of metastatic disease on the CT, you would get the same information there. So I haven't ordered that in more than 3 or 4 years.
That's reassuring. And what about genomics? Can genomics be used to predict treatment efficacy?
Great question. So this is really probably one of the hottest topics. So I think genomics should be done for all poorly differentiated high-grade neuroendocrine carcinomas. So, there are two reasons for it. Number one is the treatment we have right now is ineffective. Everyone knows that. And we need better treatments. And every now and again, you find an alteration like a mutation or a fusion or something for which you might actually have a treatment. And occasionally that treatments work really well. Example would be like a RET fusion or an NTRK fusion. And for the lower grade tumors, we just don't know yet. So I'm starting to order genomics on well-differentiated grade 3 tumors once they progress. And I have not seen a whole lot of actionable alterations. For the lower grade tumors in general, pancreatic neuroendocrine tumors have a fairly sort of many mutations that are common, like TRX and DAX and MEN1 and things like that. But none of them are targetable. So the more we test and the more drugs we get, the more relevant these tests will become. Let's say if we now have a drug that's maybe approved for a different cancer, like breast cancer, for a certain mutation, we find that in a neuroendocrine tumor, it's reasonable to try that. But right now, I mostly limit this to neuroendocrine carcinoma, much less to neuroendocrine tumors. And for the grade 1 and grade 2, I almost never test.
Okay, that's helpful. And because we know we always have newly diagnosed people here, can we just take a step back and also define what genomics is and how that gets tested?
Yeah, so there are two ways of doing the genomic testing. So essentially, we're trying to find out if there are certain like genetic abnormalities, mutations, or fusion genes where two genes have like broken apart and fused together wrong, for which we might actually have a targeted drug. So you can take the tumor tissue, which is what we prefer doing. We can, through multiple different platforms out there like Foundation One, Caris, Tempus, to name a few, we can test for mutations in hundreds and hundreds of genes, even up towards thousands of genes and more. And so that's tumor tissue. That requires a fairly sizable biopsy. And let's say if you have bone metastases, it's very hard to get that information from bone tissue. There is also the possibility of doing what's called circulating tumor DNA. These are blood tests. They typically have a lower number of genes tested, and but as I showed in that talk, for the high-grade tumors, that actually may be valuable and may even find mutations in high-grade neuroendocrine carcinoma that are not seen on tumor tissue testing. So these are the two different ways of doing this, tissue and blood. I prefer tissue. If I don't have tissue, I do blood.
Thank you. That's a really helpful explanation. You were talking about efficacy and predicting efficacy. Do you expect surgical treatment of primary tumors and liver mets to become less common as medical, nuclear medicine, and interventional radiology treatments are developed and gain efficacy?
I think this all depends on tumor stage. So for localized and non-metastatic tumor, surgery, I think, is always going to be appropriate, for given that the patient can have surgery for other reasons. For localized sort of few metastases, I think surgery is still a very good choice, and then surgery works very quickly for symptomatic disease, assuming it can be surgically removed. But that said, we're getting better treatments, and we have to be mindful of long-term toxicities of treatment, financial toxicity of long-term therapy. So if you're looking at being on a very expensive drug for years and even decades versus taking the tumor out and be off therapy for years and decades or even forever, I think we just need to weigh all of these factors. But this is actually really interesting because there is a rare syndrome called von Hippel-Lindau, and patients sometimes get neuroendocrine tumors of the pancreas, actually often get neuroendocrine tumors of the pancreas. And there is now a new drug called belzutifan that is incredibly effective. Don't have long-term follow-up, but the drug looks very, very effective. And one wonders if this drug is well tolerated, has really good long-term safety and efficacy, would we need surgery for those patients?
Yeah, that's the question. Well,
Mhm.
understandably, there's a lot of questions about PRT, so we will jump
Sure.
into some of those. What can be done to reduce the risk of bone marrow toxicity or MDS of PRT treatments? And what about the higher risk with PRT plus CAPTEM?
Yeah, so a great question. Let's try to break this down. So let's first do PRT and CAPTEM. So we know from the NETTER-1 study that the risk of leukemia in that study of more than 100 patients treated with PRT, there was only one MDS and no leukemia as of yet. More leukemias and MDS may appear later, but that's very, very encouraging. These people generally did not have chemotherapy. Then we have studies, including one presented by the Moffitt team at LACNETS this year, and studies from Australia last year suggesting that if you have CAPTEM and PRT, the risk of leukemia might be 10%. But and we're talking the risk of leukemia in the next 5 to 10 years. Well, some of these patients wouldn't have survived 5 or 10 years if it wasn't for the PRT. So you always have to weigh that in as well. So that's the CAPTEM. And the chemotherapy in general and PRT. It seems to increase the risk. To what extent, we really don't know. As for reducing the risk of leukemia or MDS from PRT, no effective therapies we know of yet. So all we can do is try to select patients carefully. So let's say if this net test, like the test, the PPQ, holds up in predicting who might respond to PRT. Let's say if you have a patient who is in need of another therapy, PRT being one option, but the PPQ test suggests that this person is not going to respond well to PRT. Shouldn't we be thinking of some other treatments before we do the PRT? Well, this all needs to be properly tested in large studies, but that is one possibility there. The other thing that we and others are looking at is called the CHIP analysis. So this is looking at the thing called clonal hematopoiesis of undetermined significance, or potential undetermined potential actually. And so this is almost like a small, like malignant clone that's just leukemia and waiting in the bone marrow, just waiting to grow into something. Sometimes it doesn't grow into anything, and that's probably what it does most of the time. But if you have one of those clones in the blood, maybe you shouldn't have PRT. We don't really know that yet, but we're actually looking at this at Mayo now.
Wow, that's really interesting. And how do we know about those clones?
So there are several different genetic ways of testing them. One of the problem is that these are often not standardized, approved tests. They can be tests on research, like done on research basis. They may not be covered by insurance. So there are certain places looking into this. There was one publication or presentation at the European Medical Society meeting from France. There was a really interesting publication from the Roosevelt Park Cancer Institute in a journal. I just didn't have time to go through that. And then I will say we'll probably have some data coming from Mayo. So even as early as early 2023.
Be on the lookout for that.
Mhm.
And what about platelets? This comes up a lot, I know, in the support group. Is there anything that can be done to increase platelets when they go down with Lutathera?
Not really. So this is the same with platelets going down with chemotherapy. So what we've done, we've when we started doing this, we said, well, we're going to set the limit of of platelets of 100, and then we've sort of slowly been going down. So okay, well, 80 is probably okay. Well, 75 is probably okay. And keep in mind that there's a set number of Lutathera treatments, 4 treatments. If the platelets are going down, as long as they're not dropping below 50 or 60, we might be able to continue safely and they will eventually recover. There is not a good drug to boost platelet production. There are drugs out there, but they just haven't been tested, and there are some concerns they might not go well with chemotherapy or radiation therapy. So my approach has really been just to delay the next treatment. Do blood counts every other week, and once we get up to 75 is typically my trigger or my limit, and then we get back on PRT. We have thought about lowering the PRT dose, but then I'm a little worried we're not giving effective enough therapy.
Yeah, and this question also comes up. Is there an impact in efficacy if the Lutathera schedule is delayed for various reasons, like the platelets? And how long can it be delayed?
Yeah. Not well studied. So probably fine to delay by 6 or 8 weeks, especially if you've had 2 or 3 treatments. We know in the early days of PRRT, both with lutetium and yttrium in Europe, we were on weird schedules, sometimes like 2 or 3 treatments months apart. So I'd like to stay on schedule as it was studied, but I've had patients where we actually waited for 4 or 5 months. But then what I do at that time, sometimes I just do another scan. And if there is stability, nothing is growing, or even if things are shrinking, I just say, let's just wait. Let's just, instead of completing the treatment all 4 cycles, let's just retreat you when it grows again. So that would be one approach.
Yeah. And what other approaches, if any?
Not really. Platelets are, for all of us who give chemotherapy and radiation therapy, low platelets are frustrating. I wish there was a better treatment for it. You can't sort of, they just do their thing, and their platelet thing. They recover when they recover.
We need that magic wand to fix it.
Oh yeah. Hopefully, I'll see some drug that can actually reliably and safely stimulate platelet production. And maybe eventually we'll get drugs that protect the blood and bone marrow from the effects of radiation therapy. But that's more like a wishful thinking right now.
That would be wonderful.
Mm-hmm.
And you mentioned so many amazing different PRT options in clinical trials. So with the various options, how do you decide whether to treat with Lutathera or the clinical trials like you mentioned, like Compose or Alpha PRT?
Yeah, so right now, all we have is Lutathera. So unless you're on trial. So let's say if you are in need of PRRT and you fit the criteria for any of the PRRT trials and a trial center is nearby or not too far away, I always think we should consider a clinical trial. Not that Lutathera isn't effective, it's the only way to move the field forward. So if that's how we got where we are right now, thanks to all the patients and their providers who actually went on these trials to show that this actually works. So that's why I really try to suggest the clinical trials when appropriate. Well, the Compose, for example, has very strict inclusion criteria. You have to meet, it has to be a KSH7 more than 15%. And there are certain other things that you have to look at. And if you don't meet those criteria, you're not going to go on the study. And that's how we do trials in a very rigorous way, so we get reliable results. And so then I would direct people to more sort of standard Lutathera. And then eventually, when we get alpha particle therapy, I think what needs to happen is a first-line PRRT study, alpha versus beta. And I don't think we should treat people off study with alpha particle therapy first line until we have data saying it's really better.
And, wondering about alpha trials, what are the typical disqualifiers for alpha PRT trials and why, if you know?
Great question. So here is a disclaimer. I've only seen one of the protocols, and these trials are coming. I'll see more protocols. So for that particular protocol, you have to have had PRRT with lutetium with Lutathera before. So and you cannot have had temozolomide chemotherapy for that particular trial. And others will have other enrollment criteria, and some of them will have, all of them will have a certain like blood levels. If you're below this in platelets or white blood cells, you cannot go on. So there will be all of these potential disqualifying things or criteria.
Okay. What alpha PRT trials are on the horizon? And one person asked specifically, is Mayo participating in alpha trials?
Yes, so the one that we're all, a lot of us are waiting for is a trial of actinium-225. So this is a retreatment PRRT trial. So this will hopefully open at Mayo in the second quarter of 2023. And so that's that's a trial that's going to open multiple different locations in the U.S. A lot of excitement about that study. So we're all waiting for that. There is currently a trial in Houston at Excel Diagnostics. So I don't know what the enrollment criteria are for that trial. So definitely something, if someone is interested in alpha particle therapy, they can definitely reach out to that facility. There will be other trials coming. I just haven't seen the protocols. Lead-212 and actinium-225 seem to be the two radionuclides that are furthest along. So I'm hoping to see some lead-212 protocols soon.
And why do you mention that you're hoping to see the lead protocol soon?
Because it's moving on in development. That's actually what's being done in Houston. So that's lead-212 dotamtate. So I'm hoping to see some of those protocols, so actually see the actual protocols, see what patients they're trying to get on.
I know that there's been questions in the community how the different alpha trials or isotopes, lead versus actinium, compare to each other. And what do you know about the two, if any?
So really no data. So no comparative data. We keep in mind that if we look at an actinium study and compare it to a lead study, the patients on these two studies may be completely different. And let's say if there's a big difference in response rates or survival, that may all be explained by the different patients. So one of them may have had heavily pretreated patients, like the trial from India I showed you there. It's a really good trial, but some of those patients were in pretty rough shape and they've had all sorts of chemotherapy, and they will naturally do a little worse than someone who probably goes in for an alpha particle therapy in really great shape and without prior therapy. So when you compare one trial to the next, always the first thing I do, I look at who are the patients.
Yeah, thank you for that. And I know this comes up probably a lot in your practice. After someone has already received 4 Lutathera treatments, how do you decide the next step at the time of progression? More Lutathera versus alpha versus chemo or
here's
other?
How I think of this. So right now with the NET retreat study coming, and we're not going to have that at Mayo, and probably not. So the reason being is that we're hopefully going to have an actinium-225 study instead. So now what I'm doing is that hoping to open the actinium-225 alpha particle study at Mayo. I try to make sort of treatment decisions. If I need another therapy, I try to think of it in this way. I try to think of it, what could I do next that does not disqualify this patient from that particular alpha particle study when it opens? Sometimes you just don't have the luxury of waiting that long. So I say it's going to open in the second quarter of 2023, but it could be longer. All of us who activate clinical trials, we know it always takes longer than we wish it took. And so it's hard to say. So there are some patients now, I say, we just can't wait for an alpha particle therapy trial to open, and the PRRT retreatment with Lutathera is the best I can offer you right now. I think we should just do it. We're probably eventually going to have alpha particle therapy trials that allow multiple prior lines of Lutathera before, but we just don't have that yet.
And could you talk a little bit about how you're doing the retreatment?
So we follow what's sometimes called the Rotterdam protocol. So when we retreat with PRRT, we want to make sure that there are at least 12 months from the last PRRT or the 4th PRRT or sometimes the 3rd PRRT until there is tumor growth. So if there is tumor growth within 12 months of completing the PRRT, then another PRRT is probably not going to be that helpful. So we wait, if there's more than 12 months from the last PRRT until tumor growth, we treat with 2 treatments, same dose as before. Instead of 4 treatments every 8 weeks, we do 2 treatments every 8 weeks. Then we pause, continue the injections with somatostatin analog, octreotide or lanreotide typically, and then we consider retreatment. So that's dose number 7 and 8 if there is tumor progression. That's where most of the data is right now.
Thank you. Thanks for that. There's a couple questions about CAPTEM. How many cycles of CAPTEM are safe? And in the CAPTEM versus TEM study, how many cycles were done?
So in the CAPTEM versus TEM study, the ECOG 2211, I'd like to say 12 or maybe 13 cycles. And so that's about a year, a little bit over a year. So the longest I've given CAPTEM is probably 3 or 4 years. And it's very, very safe. We have data from Moffitt, almost 500 patients. Long-term safety of CAPTEM alone is really, really good. The question is really, how much really do you need? And there are now more and more data coming out saying that you get almost all of the benefit with the first 9 to 12 months. So why continue beyond the 12 months if there is no additional benefit, even if there is little risk? So I'd say, and I used to treat until tumor progression. I don't do anymore. I treat for 9 to 12 months, and then I just stop.
And would you retreat with CAPTEM in the future?
Absolutely. And I'm starting someone on retreatment this week. So 2 or 3 years, we have seen now as many as 40 to 50% of patients who have really good response to CAPTEM, they can go on with stable disease for a long time. For example, one of my patients got CAPTEM for multiple liver metastases, had excellent response. This was like 3 or 4 years ago. We stopped the CAPTEM probably about 2.5 years ago. Nothing has grown in the liver since.
Yeah, wow, that's exciting. And what are your thoughts about CAPTEM for pancreatic nets and specifically grade 2, but I guess in general, any PNETs?
Any well-differentiated PNET, it works. So data would suggest that for grade 3 well-differentiated PNETs, CAPTEM has a little bit less activity. The disease control or how long you control the cancer doesn't really last as long with grade 3. There is this misconception that CAPTEM doesn't work for grade 1. Actually, it works fine for grade 1. There's a good response rate. Sometimes you have to wait a little bit for the response rate or for the responses to be seen, but the CAPTEM works for grade 1, grade 2, and grade 3.
Okay, thanks. You mentioned in your talk you prefer less shrinkage but lasts a long time versus a lot of shrinkage but doesn't last that long. Do you imagine there will be something that does both?
I think we'll eventually have it, and I think I am really curious to see what alpha particle therapy does long term. Great response rate in those small studies, but keep in mind that those studies haven't really been following the patients for that long. So alpha particle, if we're seeing response rates of more than 50%, and if those response rates last, that would be great.
That would be great. And you mentioned clinical trials and how it's helpful to move the field forward. How do patients find out what and where clinical trials are open and when there are open spots?
Yeah, so this is an ongoing headache, and you know this, where we have to figure out a way to do this better. So there is a way to look at the clinical trials through the National Cancer Institute or NCI. So if you just Google NCI clinical trials, you're going to get this website where you can type in some like information on the malignancy, including neuroendocrine tumors. But it's not an easy website to navigate, even for me, who has been using that website for over 10 years. It's confusing. So we need to have a better list of active clinical trials. And we're trying to do some of that work within LACNETS, and I know others are trying as well. I just this morning saw a website from a practice in the Midwest that is looking at theragnostics trials and listing them. So hopefully LACNETS will have something, but until then, I think the best you can do is to ask your treating oncologist about these trials. But you can certainly go on the NCI website. I find it at times frustrating.
Yeah, okay. Thank you for that. And speaking of clinical trials, and I know one of the trials you had talked about crossover, if someone goes on a clinical trial and gets randomized to the control arm where they don't get the treatment, what are the options if they wish for treatment?
So ideally, you should stay on the arm you were randomized to. So let's say we have a clinical trial and everyone who gets the standard treatment says, actually, I don't want to do that. And well, then we'll never know if the experimental drug is effective. So I think a lot of the trials coming now will have a crossover of some sort or a very active comparator arm. And like some of the subcutaneous octreotide trial, the Sorrento has either lanreotide or octreotide LAR as the reference arm. So really stay on the study if you can, and come off the trial if there is toxicity or tumor progression. So you can always opt out of a trial. I'm not saying you shouldn't do it, because at the end of the day, you really have to do what you're comfortable with. And but I tell all of my patients, if you sign up for this trial, you really need to think carefully about what you are going to do if you get randomized to the control arm. At the time of progression, we'll almost always have something to offer.
Okay. And just one or two last questions. Are you aware of any studies to identified potential environmental or toxic exposures to the development of nets?
No, not. I've been trying to start one myself, and it's just very hard to do that because it's next to impossible to measure like the level of toxic chemicals, especially if you don't know what chemicals you should be looking for. So there have been studies looking at the clusters of neuroendocrine tumors around industrial areas and mining towns and things like that, but that's all sort of guesswork. And so I'm not aware of anything. I'd love to participate in that because we've all seen, those of us who see neuroendocrine tumors, we've all seen these patients that they say, well, there are like 15 other neuroendocrine tumor patients in my little like area wherever I live. And so I'd love to see studies on that. But to my knowledge, nothing going on.
Yeah, that would be interesting to find.
Oh,
And we'll
yeah.
we'll end with this last question. What advances, well, thank you for the thorough review of 2022, but what advances do you anticipate in 2023? And then also, what final words of hope do you have to offer the neuroendocrine tumor community?
So I think 2023, I think will be like enrollment onto alpha particle studies. We probably won't have much alpha particle data yet. We're going to see long-term follow-up of certain trials, including possibly some of the previous PRT trials. The COMPETE trial of lutetium dotatalk versus everolimus might read out. I'm not a part of that team, so but that might not be in 2023. There might be some other trials in Europe that we're not aware of. There might be more information on genomics. And then we have some of the targeted therapy trials, which probably won't read out anything yet in 2023, like cabinet. I think that's a little too early. But I think we're going to see a lot of trials start. We're probably going to see some early results from the phase 1 studies that might actually direct us towards what to do next. So I think on a hopeful note, there has never been more activity in neuroendocrine tumor research than now. So I've never seen as many trials. I've never seen as many publications. So, and I have no idea what all of my colleagues all around the globe are doing. So I just, every Friday when I get my publication list for the last week, I'm like super excited. So what's new?
We love that passion and
there will,
excitement.
trust me, there will be something.
Yeah, well, we love all that passion and excitement. Thank you for your dedication, hard work in this area, for giving us this thorough review, and we look forward together to going into 2023 and seeing what comes next.
Always a pleasure. Thank you for inviting me.
Thank you so much, and I'm going to send it back to you in the studio, Rich. We want you to know that you are not alone. To this end, we offer many programs and resources, including our weekly virtual NET support group, our monthly dedicated caregiver-only support group, our NET Connect mentor program, and our health and wellness coaching. My husband was diagnosed with advanced pancreatic neuroendocrine tumor 8 years ago, and the connections made through LACNETS helped us in our journey of making neuroendocrine tumor decisions. We encourage you to go to our website, lacnets.org, to find out more information about our programs, view resources, download Net Vitals, a patient-physician communication tool to help you prepare for your medical appointments, read blogs, take NET quizzes, and much more. LACNETS also has a monthly podcast featuring experts who answer the top 10 questions in their field. Our most recent episode is on psycho-oncology. Next week, we will release our December episode featuring the best of NANETS. We encourage you to take a listen. Here is our Executive Director, Kavya Velakapudi, to explain more about our Vision campaign.
As we mentioned earlier, LACNETS was founded in 2012 by jazz musician and composer Giovanna Joyce Mbezi, who was a NET patient herself. Giovanna was diagnosed in 2005 with metastatic small bowel neuroendocrine cancer. She then pursued her MBA for the sole intent and purpose of launching a NET patient advocacy group in Los Angeles. She lived fully with her diagnosis for 14 years. Our NET hero passed away in November 2019 and left behind a legacy and a vision to empower NET patients to live richly and fully. To this end, we have launched the Vision Initiative. It's been 3 years since Giovanna's passing, and we continue to carry her vision forward. And we want to support you as you learn to adapt to your new normal and to empower you to live richly and fully. So we invite you to contribute to Giovanna's vision and to help continue what she felt was her greatest legacy, LACNETS. Your gift will be matched 100% if you contribute by December 31st. Large or small, every gift matters and is greatly appreciated. Please consider paying it forward and help other NET patients and loved ones. We also invite you to share the word and spread the vision to your family, friends, and community. Over to you, Heather.
Thank you, Kavya. Again, follow us on social media to stay up to date on our upcoming events and net news. Our handle is @LACNETS. A sincere thank you to Dr. Halfdanarson for his expertise, insight, and taking us through the NET 2022 year in review. Thanks again to Rich, our technical director at TVP Live, for this high quality broadcast. And thank you all for joining us today. Goodbye and take care, everyone.